broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everyone, and welcome to another edition of the RX Question Lab. I'm your host, Jeff Downing, and we are pleased to have you tonight as we embark on a journey to enhance our ability to answer board-style questions. And tonight, we're going to focus on respiratory physiology. So here at Question Lab, we believe that answering NBME style questions is one of the highest yield activities you can engage in while studying for the boards. We also understand that these questions can be complex, and without the right approach, they can sometimes seem insurmountable. So that's where we come in. Our mission is to help you develop the skills to dissect these questions effectively and efficiently. And we're going to do that by breaking them down together in real time. And you can have a chance to ask questions of the team in the chat. So, hopefully you're going to pick up some advice and sharpen your skills a little tonight. So tonight, as we focus on respiratory physiology, I'm going to be assisted by my co-host, Dr. Abraham Titus. Abraham, would you mind introducing yourself to the crowd?
Sure. Well, it's my pleasure to be here today. My name is Dr. Abraham Titus. I'm a hematology and oncology fellow at University of South Alabama. I've been a tutor with RX for about 5 years now, actually. I started before my residency, and I've helped multiple students, such as yourself, achieve their goals on step 1 and step 2. We follow a systematic approach to answering questions, and as you'll see, it helps you understand what the question writer is asking you and really learn the most from each question.
Excellent. Thank you, Abraham. We're also joined tonight by Kate. So she's going to be in the question box there working to answer your questions. So feel free to drop her a line if you're having any issues. So let's go ahead and we're going to start tonight with question number 1. And the first thing you're going to note is what's missing from this screen, and that, of course, are the answer choices. So that's by design. That's our first step, is to say cover up those answer choices, and we do that because invariably you're going to see some answer choices that you don't remember, or that you've had trouble with, or that you've been confused about, and so it's one of those things that can knock you off your game. So we say cover up those answer choices first, because what you really want to do first and foremost is focus on the question, right? And so our step 2 is to say read the lead-in, okay? Read the actual question. So in this case, the lead-in is, which of the following is this patient's most likely diagnosis? So we've got those answer choices covered up. You're now focused on the question, and by looking at that, okay, hey, this is I'm going to try to figure out what the diagnosis of this patient. So that means as you're reading through the vignette, you're reading through that case. You have a clue as to, well, what kind of data should I be looking for? What am I driving towards? Okay. So with that, let's read that vignette. A 67-year-old man comes to the office because of a 4-month history of worsening non-productive cough and exertional shortness of breath. He is a retired construction worker and has a 40-pack-year history of cigarette smoking. An X-ray of the chest reveals multiple small rounded opacities, approximately 5 mm nodules, mostly in the upper lobes, calcification of hilar nodes, and central calcifications. The pulmonary function test results are shown in the graph. So again, the question, which of the following is this patient's most likely diagnosis? Go down to the question box. Let us know how many steps you think it's going to take to answer this one as I turn it over to Abraham.
All right. So Jeff mentioned a couple very important things, right? So the fact that we read the lead-in first kind of gets an idea of what we're looking for even prior to getting to the vignette. This is a little shorter vignette, but there are going to be situations where you're going to have really long full-page vignettes where you don't want to get confused and zone out while you're reading it. You want to know what you're looking for and pick out the key information as you get through it. So as we read through this question, what are some key words here? So let's start with the beginning, right? So most likely diagnosis is what I'm looking for. A 67-year-old man. I always want to know my demographic. Who am I going to be seeing with, and what can I expect in that open? And then 4 months, right? The symptoms have been going on for 4 months. That gives me the acuity, the level of if it's something that's very fast, that's happening really quickly, or something more chronic, something else going on. Okay. And then the chief complaint, obviously, that kind of comes into it, the non-productive cough and the shortness of breath. And really, the occupational stuff that shows up next is also important, right? He's a construction worker that's retired. Now, construction worker can mean many, many things, right? So this is, they can use the word laborer, construction worker. They're not being specific. So this can mean, you know, someone that worked in a shipyard situation, someone that's a plumber, someone that is a miner, a sandblaster. All these things can be compiled as construction worker. You can't classify them. Sometimes they'll give you specific jobs. Sometimes they'll give you more general terms like laborer or construction worker. And he also has a 40-pack year history of smoking. So that is high yield, that he has a high, risk of pulmonary disease with the smoking. So he's got, a few risk factors here, and we have to think about that. The X-ray shows multiple small nodules. So the small rounded opacities are kind of high yield there. What are we looking at that? And it's in the upper lobes. Okay, location is key in this one as well. That's a clue. And the fact that they are calcified is pathognomonic for something. Now, what's next? What is the next thing? You have this graph here. This graph is a volume to time graph. I want you to pay attention to that. So the volume, and you got to think about what's normal, which is what the white boxes are, and the black boxes is what the patient is. So you have to think about what's happening. So the volume, is that increasing or decreasing? And how does that trend as it goes down, as they exhale what's happening? So that's what you got to pay attention to. So you want to use all that information, and then when you look at the options, you want to have one answer in mind. All right, Jeff, so we can pull up the options now so we can.
Yeah, hold on. I have to get back to
erase them. Yeah.
Get back to my pointer. Sorry.
All right, so here are our options. And another trick that we'd like to always think about is start with E and make your way up, so that we don't get followed into the trap. All test takers expect us to go from A to E, and they sometimes build questions in a way where they want you to pick the first answer you see, or don't pick the first answer you see. So I always like to think about, let's start with E and go up. So option E is silicosis. Option D, mesothelioma. Option C, chronic obstructive pulmonary disease. Option B, berylliosis. And option A, asbestosis. So what's going on here?
Okay, well, what we're going to do is we're going to launch the poll and have you tell us what you think the most likely diagnosis is. We always remind you to ensure that you answer every question on test day. You're not going to get penalized for it. It's good to have a strategy for that too. Okay, let's see. About a half of you have voted. A good mix of responses so far. So I'll give you a few more seconds. If you haven't cast your vote yet, go ahead and do it. Okay, let's go ahead and close the poll, and we'll share the results. So it looks like answer choice E, silicosis, was the top vote getter, almost 40%. Mesothelioma and asbestosis, both right over the 20% mark. And also some folks went with COPD, and a couple of you went with berylliosis. Okay, so let's hide the results and share the answer. And the answer is answer choice E, silicosis. So congratulations, that's your first win of the night for the crowd. Good job. If you didn't get it, that's okay. We're going to walk through it right now. Abraham.
All right, thank you, Jeff. So good job on who picked silicosis. If you did not, that's totally fine. This is a tricky question, right? This person has multiple risk factors. Just based on the story, the patient is a construction worker. So that means that he could have been any kind of occupational exposure. So it does not specify. Typically, when we think of silicosis, these patients are what they describe as sandblasters. That's going to be the buzzword that they give you for occupational. That typically means that someone who's working at quarries, blasting sand at machinery to remove rust, that's the kind of story that they're going to go for. But again, the general term construction worker should encompass that. Now, he does have a 40-pack year smoking history, and that does put him at risk for COPD, but that would not match with the graph. Let's look at the graph here. The volumes are reduced, and as we know, when we see reduced volumes, that should make us think of restrictive lung disease, not an obstructive pattern. Okay, so understanding the patterns between a restrictive lung disease and obstructive lung disease is very high yield. That's something that we definitely hit on when we talk about this with the students. So the graph here will show us that, hey, we're dealing with a restrictive pattern of lung disease. So that right away will illuminate option C. Now let's look at the other options. We have option A, option B, and option D, and option E. They're all technically can be considered restrictive lung disease, except mesothelioma is more of a malignancy. It's a cancer. There's no mention of a mass in the pleura, anything that's even pointing towards a mesothelioma in this situation. The pathognomonic clue in the stem is the calcification of the hilar lymph nodes. Does anyone know what that's called? There's a buzzword that they use, and it's something that they always drive home. They're called eggshell calcifications. So eggshells are calcified. So if you think about when you look at an eggshell, it's white in color. So that's why the hilar lymph nodes look like little eggshells, because they're calcified, and that is got to do with silicosis. Silica particles get taken into our lungs. Our macrophages can eat them, and that can then fibrose the lungs and also turn off our macrophages. These patients are at high risk for miliary tuberculosis, and that's another buzzword. That's another way they can ask the question. Let's go through the other options. Asbestos. Asbestos, it's going to be someone who's a shipyard worker, plumber, or construction worker. And the big clues are going to be talking about something with a pleura, so pleural plaques in place. And the way that they describe the nodules, it will be more in the lower lobes. And I think one of the mnemonics in first aid that really hits on this is asbestos is typically found in the roofs because it's insulation in the roofs, so therefore it's in the base of the lung. Whereas silica is found in the ground when you mine, and it's found in the top of the lung. So the opposite there is very true, and that's a big clue that you can think about. So when they say upper lobes, I want you to think of more silicosis, especially when it has the central calcifications. And if you hear lower lobes and somebody is working as a plumber and there's association with pleural stuff, that's when you got to think asbestos. Berylliosis is pretty rare. It's unlikely you're going to get a question on it. It's always going to be a distractor option. It's got to do with someone working at NASA, aerospace materials. Pretty unlikely for that to be the clinical situation. And again, COPD here, we have a restrictive pattern. Definitely not the case. And mesothelioma, there's no mention of any malignancies, no mention of pleural plaques or masses in the pleura. So the answer here is silicosis. Good job, guys.
Excellent. Yes, great start for the night, and lots of good tips there from Abraham on what you should be looking for in those types of questions, and what would tip you off if if that vignette was a little bit different, right? And that's always a good thing to think about when you're reviewing questions. Hey, what would that vignette need to say in order for answer choice A to be right, or answer choice D to be most likely? So good tips to be thinking about. Okay, we're off to a good start. Let's go ahead and start question number 2. Okay, so again, we've got all of those answer choices covered up, and we're going to start with the lead-in. Okay. Which of the following is the mechanism of action of the agent most likely causing this patient's symptoms? Okay, so right off the bat, you've got a multi-step question here, and you're going to have to sift and sort through the information in the vignette to try to get to that answer. So let's do that now. Let's read the vignette. A 30-year-old man is brought to the emergency department because of shortness of breath, dizziness, nausea, vomiting, and palpitations after entering a burning building to save his neighbor 2 hours ago. On physical examination, pulse is 90, respirations are deep and gasping at a rate of 30 a minute, and blood pressure is 80/60. He has bright red vessels in the retina of both of his eyes and an unusual acrid odor on his breath. So again, the question, which of the following is the mechanism of action of the agent most likely causing this patient's symptoms? Love it for you to go down to the question box. Let us know how many steps you think it's going to take to solve this one as I pass it over to Abraham.
All right, so another great question here. This one's a little bit different, right? This has not really got to do with our typical work exposure, smoking. It's somebody who's running into a burning building and then coming out with all these symptoms. Now, a few things should be going through your mind. Let's go through and think about what's the most high yield terminology in this question. So first of all, the lead-in, which of the following is, so the mechanism of action of the agent most likely causing it. So it's not just asking you the agent, it's asking you to diagnose this guy, thinking about what exposure he had, and then how that exposure works to cause this problem. All right, let's read through this. So 30-year-old man, I like to always think about, demographic. Who am I dealing with here? Okay. And the general complaint, again, he has some vague symptoms, but shortness of breath is kind of the main thing we're focusing on here. And he entered a burning building. So that's a big clue, right? So it kind of tells you, okay, things you're thinking about, inhalation injury, things along those nature, what can come along with burning. Now, the presentation otherwise, he's been going on, pulse is 90, okay, it's fine, gasping, respiratory rate of 30. That's pretty important, right? It's part of the shortness of breath. He's breathing really fast, trying to get that oxygen in him. Blood pressure is also a little bit low, 80/60. So something should be thinking about that as well. And then bright red vessels. Why would they mention that? What's important about those bright red blood vessels that we have going on? And this acrid odor. What is acrid odor? So I'm not going to tell you guys. I want you guys to think about what that means. That's a terminology they use a lot in step vignettes, and we'll talk about that when we go over the answers. But that's a kind of a little bit of a buzzword if you didn't get the answer from the initial step. All right. All right, so we got some great options here, and these are some tough ones. Okay, so I want you guys to think about that. First, you got to think about the diagnosis, and then really think about how that would work. All right, so option E, uncoupling of the electron transport chain. Option D, inhibition of the electron transport. C, inhibition of an ion channel. B, inhibition of adenosine triphosphate synthase. Or A, decreased blood oxygen carrying capacity. Again, this is a tough question. I want you guys to think about this one and go ahead and pick an answer that fits the answer the best.
Okay, we've launched the poll. So again, a lot of information, a lot of data points for you to to process. Which of the following is the mechanism of action of the agent most likely causing this patient's symptoms? Okay, how are we doing so far? We've got about half of you have voted, and so far it kind of looks like a two-horse race. We'll see how that plays out. Not unusual in that regard. Great to see so many of you out here tonight. If you're a first timer, let us know in the question box. Always love to hear from the newbies. Okay, let's see. 3/4 of you have voted, so let's go ahead and close the poll, and we'll share the results. Okay, so in this case, almost half of you went with answer choice A, decreased blood oxygen carrying capacity. And a little under a third of you went with inhibition of electron transport. We've got some of you were thinking uncoupling of the electron transport chain, and a few of you were thinking inhibition of an ion channel or inhibition of adenosine triphosphate synthase. So interesting spread. Let's go ahead and hide the results and reveal the answer. And the answer to question 2 is answer choice D, inhibition of electron transport. So as Abraham noted, this tougher question tripped up about 2/3 of you here. So that's okay. That's why we're here. If you're going to get the answer wrong, get it wrong on question lab, and so you get it right on test day. But Abraham, we're going to need to walk through this one.
Yes, for sure. And this is a question, don't feel bad about getting wrong. This is a purpose question that's really meant to test your knowledge on the intricate details and differentiate between two very similar diseases. Diseases that are both associated with burning buildings and coming in with, red vessels and hypoxic and shortness of breath story that this patient is coming in with. There's a few clues that point away from one thing and towards another, and that's what we're going to talk about today. So again, don't feel bad about getting this one wrong. Most people picked A, and I know exactly why they picked A. So let's go through what is going on with this patient. So when someone comes out of a burning building, the two things that should be going off your mind is it carbon monoxide poisoning, or is this cyanide poisoning? Both things are present in the air when we burn things. Typically, laminated material like couches and stuff contain some cyanide, synthetic fibers, and those can burn and cause cyanide toxicity. So this patient kind of fits more with the cyanide toxicity picture as opposed to the carbon monoxide toxicity. Now, what tells me that? So the acrid odor, that's going to be one of the big clues in this question that's pointing to it. So acrid just means burnt almonds, like the nuts, the bitter almonds kind of smell, and that's what acrid means. So that typical smell to their breath should ring some bells right away, and hey, this should be cyanide poisoning going on. Very common in household fires, just like carbon monoxide poisoning, which is also a good thought. So when we think about cyanide poisoning, how does cyanide work? Well, cyanide, we know, we've heard it before, it's a poison to our body. But how is it a poison? And that's the level we need to understand it at. It inhibits the electron transport chain. So what does that mean? So within our oxidative phosphorylation, right, in order for us to make ATP, think way back to biochem, think back to molecular, think back to when we learned early basic science concepts, when we go to make the NAD and FAD from our Krebs cycle, we put that into the electron transport chain in order to pump out some ATP. Now, part of the electron transport chain is something called complex 4. And what happens is the cyanide binds to the iron within complex 4 and completely turns it off. So if without that, we can't use our oxidative phosphorylation. We can't create ATP as efficiently as we want to. So what's going to happen? Our body is going to switch over to anaerobic phosphorylation. And these patients, another big clue they can give you is an elevated lactic acid level, because they are dependent now on anaerobic phosphorylation. And we know lactic acid is a byproduct of anaerobic phosphorylation. So the option here that is correct would be option D, inhibition of electron transport chain. Let's go through the other options really quickly, okay? Uncoupling of the electron transport chain, again, that's not the answer. That's not how cyanide works. There are some other agents, uncoupling agents that work there. Again, those are lower yield, not worth our time memorizing these other drugs that we don't use anymore. Okay, let's look at the other options here. So we have option C, inhibition of an ion channel. Again, that's not how it's working. There's some toxins that work on there, but that's not how cyanide works. Same thing with option B, inhibition of, this is ATP synthetase. That's also part of the electron transport chain, the last step of it. There's also an agent called oligomycin that inhibits that. Again, that is a little bit on the lower yield side. The high yield point from here is cyanide inhibits complex 4, which then inhibits electron transport chain. Let's go to option A. This is the one that tripped everybody up. This is carbon monoxide poisoning. Carbon monoxide, we know, likes to bind to hemoglobin. It competes with oxygen for the hemoglobin spots. So therefore, if you have carbon monoxide poisoning, you reduce the blood's oxygen carrying capacity. Okay, but in this situation, the patient has the acrid odor in his breath, which points away from this, and the idea for that's going to be really the big clue in this question. If you didn't get that, it kind of makes it a tougher question. The red vessels you can also see in both carbon monoxide poisoning and in cyanide toxicity, but the hypotension fits a little bit more with cyanide toxicity, and the overall picture, you really had to know this acrid odor in the breath. And that's just something I wanted to drive home today, make sure we got that concept locked down.
Excellent. Thank you, Abraham. Yep, always got to be on the lookout for the almond breath. Okay, so so far so good. Halfway home, and we've had two really good questions, and I think you've picked up a number of good high yield points to carry with you going forward. So everyone can take a breath, and we can start the second half of our question lab with question number 3. And I just want to note we are going to have a raffle at the end of tonight's session. One lucky participant is going to win an RX 360 Plus subscription. So if you are interested in that, you want to hang out, you need to be present in order to win. Okay, and we'll also have a special offer for everybody. Okay, let's go ahead and reveal question number 3. Okay, you can see a couple of x-rays on there. So in this case, we've got the answer choices covered up, and we're ready for that lead-in. Which of the following additional findings is most likely in this patient? Okay, so we know we're going to be looking for more about what would tip you off about this particular patient. So let's go and read the vignette. A 63-year-old man comes to the physician because of progressive shortness of breath and a persistent morning cough. He has smoked 1 pack of cigarettes daily for the past 40 years and had a myocardial infarction 5 years ago. Temperature is 36.7, pulse is 90, blood pressure is 126/80, oxygen saturation is 85% on room air while at rest. There are bilateral wheezes on expiration with an inspiratory-expiratory ratio of 1:3 on pulmonary examination. X-rays of the chest are shown. So again, the question, which of the following additional findings is most likely in this patient? I encourage you to head down to the question box. Let us know how many steps you think it will take to solve this one as I pass the baton to Abraham.
All right, thank you, Jeff. So this is another tricky one. So you got to start thinking about what's going on right away. you don't have to be experts. We're not expecting you to be a radiologist, but there's a few clues that you should always look for on x-rays. And I'm going to talk about that as we go into the answer. But let's do the first thing first, the lead-in. Which additional findings am I looking for in this patient? So it's not asking about diagnosis, it's asking about what else can I expect? So I have to already have that diagnosis in mind. All right, so start off, 63-year-old man. Okay, it's an older gentleman, not super old, but older gentleman. And progressive shortness of breath and morning cough. Okay, he's smoked for 40 years. And he's at an MI 5 years ago. Okay, may or may not be important there. Other key important, his oxygen saturation is 85% on room air. So that is definitely hypoxic, right? Below 93, we're thinking hypoxia at this point. And he has bilateral wheezes on expiration. There's differences between inspiratory wheezes and expiratory wheezes. And we'll talk about that. And the inspiratory-expiratory ratio, or the IE ratio, is 1 to 3. You got to think about, is that normal, abnormal? We'll talk about that as well. And we have an x-ray here. So an x-ray, it should look a little weird to you, right? If me and you got an x-ray, it shouldn't look like this. What is kind of abnormal about that? What points us towards one direction? And I want you to think about all those things as you look at the options. All right, so what additional finding are we most likely to see in this patient? Option E, increased serum erythropoietin levels. Option D, increased lung elastic recoil. Option C, decreased total lung capacity. Option B, decreased serum bicarbonate. Option A, decreased left ventricular ejection fraction. Again, this is not an easy question, so I don't want you guys to get too, hurt if you don't know this right away. This is something that takes experience and takes some practice to get good at. Okay, but I want you guys to think about diagnosis and then think about what the answer could be.
Okay, well, what we're going to do is we're going to launch the poll, and you can let us know, based on what you think is going on with this patient, what other additional findings would you expect? So again, these, I know we've got some M1s in the house tonight, and we've got some M2s, some IMGs. Sometimes you think about USMLE step 1. Okay, well, these are going to be good, straightforward questions. Now, actually, there are a lot of multiple step questions that you're going to find in step 1. The exam is certainly more clinical than it used to be, so these challenging questions are things you can expect. Let's see, about a little over half of you have voted. I think I'm sure some of you are like, I'm not sure. You might be wavering between two options. That's okay. Go ahead and pick one. I'll give you a few more seconds here. Okay, so we've good participation here tonight. Let's share the results. So highest vote getter was answer choice E, increased serum erythropoietin levels, whereas decreased total lung capacity racked up about a quarter of the vote. And then the other three options all got in the 10% range. Okay, interesting. Let's go ahead and hide the results and reveal the answer. And the answer is indeed answer choice E, increased serum erythropoietin levels. Great job, everybody. Tough question, no doubt about it, but you guys were able to break the code. Nice work. If you didn't get it right, that's okay. Abraham already told you this is a tough one. So let's figure out how to get to that answer, Abraham.
All right, so good job, guys. I really thought more of you guys would get this wrong, but I'm happy to see that 44% of you guys got that correct. So what is going on with this situation? So we have a 63-year-old guy. We know he's a smoker, and he's coming in with hypoxia, 85% on room air. He also has expiratory wheezes. That should kind of think about, okay, there's some clues going on there. And this IE ratio is normally 1 to 2. So it's 1 to 3. So his expiratory phase is much longer. And if I look at the x-ray, look how big the lungs are. The lungs should not look that big on an x-ray. So those are all clues pointing to it. There's some kind of obstructive issue going on. Okay, when I think about lung diseases, I got to separate them between restrictive and obstructive. Remember in question 1, that was a restrictive situation. Lower lung volumes, and all my pneumoconiosis are going to be my differentials at that point. Or anything that's restrictive, things like ARDS, things that fibrose the lung. That's the way you got to think about it. In this situation, the lungs are huge. They're big garbage bags instead of little bags that we like. So what's happening is that this patient is a smoker, and this patient has this obstructive pattern lung disease. So first thing that should come to mind is COPD. He has that persistent morning cough, that shortness of breath, the increased IE ratio. All things point towards COPD in this situation just based on the story. Let's look at the options. So option E, increased serum erythropoietin levels. So this takes a couple steps to think about, right? What is erythropoietin? Erythropoietin is our body's mechanism to make more RBCs. Why would our body make more RBCs? Our body makes RBCs to carry oxygen. So when we have a chronic hypoxic state, it is a trigger for our body to be like, hey, my organs are not getting enough oxygen. I need more RBCs to bring me more oxygen. So therefore, it's going to trigger erythropoietin secretion from the kidneys to make the bone marrows work extra hard to make even more RBCs. So that's why patients that are chronically hypoxic will be polycythemic. They'll have more RBCs in their serum. That's why the answer is the correct answer. Let's look at the other options though. Increased elastic lung elastic recoil. Now, the terminologies elasticity and compliance are very high yield for respiratory physiology. You have to understand what makes something elastic and what something makes compliant. In this situation, an obstructive lung pattern, or COPD, is going to be more compliant, less elastic. Whereas a restrictive pattern is going to be more elastic, less compliant. That opposite balance is very important to understand. Now, just like we said, look at the x-ray. Look how big the lungs are. So we have lots of extra space in the lung. So total lung capacity of the lung will increase. All right, let's look at option B now. Decrease serum bicarb. Oh, well, let's think about this one. This one's a little bit tricky to think about. So what is bicarbonate? Bicarbonate is a base. And we know CO2 is an acid. Carbon dioxide is an acid that we can build up in our body. See, people with COPD, they end up building up carbon dioxide in their body because they're not able to breathe out properly. How do we get rid of CO2? We breathe out. So when they have this obstructive pattern disease, we call them CO2 retainers. They hold on to a bunch of CO2. They become more acidotic. How does our body compensate for that? We have respiratory acidosis secondary to COPD. So our body will have metabolic alkalosis to compensate for that. And that's where this serum bicarbonate will increase in a COPD situation. Okay, that's a little bit trickier. When you go into acid base, you'll really understand the mechanism of it and the difference between metabolic and the respiratory side of things. And option A, decreased left ventricular ejection fraction. Really nothing pointing towards heart failure here. I understand he's hypoxic, but really on the x-ray, you don't see any pulmonary congestion and no edema, nothing really pointing towards things or crackles in the lungs that point towards heart failure story. So this is a pure lung pathology story. That's why the answer is option E, increase erythropoietin levels in order to increase my RBC count, in order to provide more oxygen to my tissues. It's a compensatory mechanism.
Okay, very good. Thank you, Abraham. Good breakdown there. And nice work, everyone. This is where, when the highest vote getter gets it right, then we consider that a win. So we're 2 for 3 here. Let's see if we can go 3 for 4 with our final question of the night. So this is our last question. So let's focus. Let's see what we can do to get this one right. Again, we've got the answer choices covered up. However, in this case, you can see that within the table, the answer choice options are kind of laid out there. So ignore that for a second. Let's focus on the question. Which set of arterial blood gas values presented in the table is most likely in this patient? Okay, so we know what we're going to be looking for here. So with that information, we can read the vignette. A 55-year-old woman comes to the clinic because of 24 hours of palpitations, shortness of breath, and chest pain on inspiration. 5 days ago, she underwent mastectomy of the right breast due to ductal adenocarcinoma. Pulse is 112, respirations are 33, blood pressure is 110/77, and oxygen saturation is 90% on room air. An ECG shows sinus tachycardia. An X-ray of the chest is normal. So again, which set of arterial blood gas values presented in the table is most likely in this patient? And with that, I'm going to turn it over to Abraham.
All right, thanks, Jeff. So for this last question, we got a little table to deal with. We got an ABG, arterial blood gas, right? So we have to be able to interpret these blood gases and be able to understand what's going on. And the typical things we look for are going to be my PCO2, my PO2, and my bicarb. That's always what I'm thinking about when I'm thinking about an ABG. So the question is asking, which set of ABGs in the table is most likely in this patient? All right, so I got to think of a diagnosis. I got to think of an ABG that's going to match the diagnosis. All right, let's look at the vignette. So a 55-year-old woman. It's pretty important in this situation. So let's think about that. And 24 hours of palpitation, shortness of breath, and chest pain on inspiration. That's a specific kind of chest pain. And there's a terminology for that, which I will talk about as well when we go over the answers. Okay, and recent malignancy, right breast cancer, had ductal adenocarcinoma, and had recent mastectomy. So some kind of surgery for some malignancy going on. Okay, that could be a big clue going on. She is heart rate's up 112 and respiratory rate's up as well. Blood pressure's okay though, so we don't have to worry about that. Oxygen is 90%. It's a little bit low for room air for someone who shouldn't have lung disease. Typically, you'd expect someone without lung disease to be like, in the mid 90s. And then the EKG shows sinus tachycardia. Okay, so not seeing any big ST elevations, not seeing anything crazy there, but sinus tachycardia. X-ray of the chest is normal. Okay, so what's going on here? What would connect all these things together, and what is a unifying diagnosis that would make all of this make sense? All right, let's think about that. We have our options already laid out for us. I don't need to wait for those, so we can look through the options here. They're different pHs. We got different PCO2s, we got different PO2s, and different bicarbs. And if you guys need help with the normal values, again, pH, you're thinking more 7.35 to 7.45. You think PCO2, you're going to think in the 30s, 40s range again. And then same with the bicarb, you have to also think about the normal range of it, okay? If you guys need to pull up the normal range on the side, you have that on exam day. Make sure you take use of it. I know sometimes people say memorize lab values, but if you really need to confirm it, you're better off always checking the lab value, but always, remembering it off the top of your head is always going to save you a little bit of time. And again, we can always use more time on exam day. So let's think about what's going on and let's go forward with that.
Okay, I want you guys to take a look at that table. Figure out which row you think is closest to the set of ABG values you'd expect. And then I'm going to launch the poll. Once I launch the poll, all of the data here is going to go away. That's why I'm keeping it up here for just another second or two. So let's go ahead and launch it. Which one do you think it is? Again, we're going to have a raffle here in just a couple of minutes here after we work through the answer here for question number 4. I'll give you a few more seconds to cast your vote. Okay. Well, let's close the poll. And we're going to reveal the answer. And the answer is answer choice E. And we've got that laid out here. So just sharing the results there. About a third of you got that one right. That is the leading vote getter. So that's well done. Well done again. But quite a few of you got tripped up a little bit. So Abraham, let's walk through this one.
Yeah, this is another tricky one here. I want you guys to first think about what could the diagnosis be in this situation, right? So there are a few clues here. The fact that 55-year-old woman, okay, and the female woman had a recent malignancy. So what does malignancy put you at risk for? And a recent surgery as well, that puts you at risk for something. So people that have cancer and people that have surgery recently are always at higher risk for forming clots. And clots are usually not a good thing in the body, right? We need clots to prevent bleeding, but when we're not bleeding, we shouldn't be forming clots in our body. So when we form these clots in our body, they can make our way into the lungs and cause what we call a pulmonary embolism. Now, what is a big clue here that's pointing towards a pulmonary embolism? The acuity of it, so it's happening 24 hours and it's just happening acutely. The association with a shortness of breath with the chest pain, right? So when you think of chest pain and shortness of breath together, things you should be thinking about. MI, is this a heart attack? Is this a pulmonary embolism? Is this a pneumonia? Is this something traumatic or pneumothorax along those lines? If I'm thinking pneumonia, anything lung related, I should ideally see it on x-ray. His x-ray is completely normal. They don't even expect you to interpret it. They're telling you x-ray is normal. So that should point you away from a parenchymal lung problem. Is it pulmonary edema or pneumonia or anything along those lines? Now, his EKG shows sinus tachycardia. That points you away from an MI or an ischemia story. And the pain that he has on inspiration, that's what we call a pleuritic chest pain. That's a very classic chest pain that's associated with PEs. When I take a deep breath, my pain gets worse. And it's also associated with pneumonias as well, but the story here doesn't really fit the pneumonia picture. With the hypoxia as well, that fits with this as well, with the recent surgery. Now let's delve a little bit deeper into this ABG, right? So interpreting ABGs is a skill in itself, and it does take some practice. So we have to think about what could be causing these problems, okay? So first thing I like to always think about is, okay, primary problem in his situation or her situation is the fact that she has a clot in her artery that's leading to the lung. Therefore, she's having a tough time oxygenating herself. So lack of oxygenation is a primary problem. So right away, I'm going to go for only the low oxygen options. So that right away, option C and option A should not be considered, right? They are in situations where oxygen is normal. And even option D, it's giving you 77. Technically, it is in the normal range, but it's a little bit lower than normal. So we'll keep that in the options for now. Now let's think about, she's breathing 33 times a minute. Normally we should be breathing maybe like 12, 15, 33 is a lot. You tire yourself out if you're breathing 33 times a minute. So when you breathe 33 times a minute, means we're blowing out CO2 33 times a minute. So we expect the CO2 to be low. This is a respiratory alkalosis situation, okay? Whenever we have a pulmonary embolism, we expect hypoxia and hypocarbia. We expect the CO2 to also be low. So that should be a big clue here. And just by looking at this and crossing out options and going from there, we can already start seeing what the answer is going to be. So let's look at the options. Option E fits us perfectly. We have somebody, let's put the pH aside for now. Let's look at the CO2 and the oxygen. The oxygen is low and the PCO2 is also low, right? The fact that he's breathing so many times per minute will make him hypocarbic. And as we said earlier, PCO2 is an acid. So as we lose the acid, we lead to an alkalosis picture. So pH is 7.56, and that's a higher end. Okay, and then the sodium, the bicarb level also fits with that story as well. It kind of matches with the story. The normals is 22 to 28. We are on 22, so a little bit on the low normal side of things, which is what we expect of this. Okay, now let's look at the other options here. Option A, you have a acidosis picture. The pH is 7.2, and the PCO2 here is listed as 35. So that's technically within normal ranges, right? 35 to 45 is you're thinking PCO2. So why would you have acidosis with a normal range PCO2? Well, the bicarb is low. So option A is pointing more towards a metabolic acidosis picture. The fact that your bicarb is low and your PCO2 is okay, but your pH is still low, that fits with more metabolic acidosis. And that's not what's happening in a pulmonary embolism. Option B, you have a slightly acidotic pH, you have a very high PCO2, and you have a low oxygen with a high bicarbonate. So option B, I would fit more with a COPD-like story. Somebody who is a chronic smoker, productive cough. Those patients, we said, retain their CO2, puts them at respiratory acidosis with the compensation being the bicarb being high as their metabolic alkalosis compensation. Again, acid base is a whole topic in itself, and we can go delve very deep into it, but I want to keep it very simple, keep it straightforward so we can keep the main points going. And option C and option D, again, as you see in those, the oxygen levels are not low in those, and option D, the CO2 is high. We expect the CO2 to be low. So option E is definitely the correct answer and would fit the overall story. Even if you didn't get the pH correct, I need you to diagnose that this lady has a pulmonary embolism. You got to get into the practice of recognizing who has pulmonary embolism. Someone comes with chest pain, think about your differentials and use the information they give you to narrow it down.